My name is Bob Sherrar, and I'm the current chair of the section of Public Health and Preventive Medicine for the College of Physicians of Philadelphia. I'd like to welcome you to the college this evening and welcome you to the first in-person public health grand rounds that we've had since the COVID pandemic began in March of 2020 in Philadelphia. It's very nice to see many of you in person after seeing some of you on Zoom. The pandemic has been hard on the public health community. Nationally, we've lost a number of individuals and public health professionals who left public health to do other work. It's going to take us a while to recover from the pandemic, but we will eventually. Philadelphia, though, is fortunate in the fact that we have in the area a wealth of what I call public health capabilities. We have 8 schools that offer training in public health programs. We have 5 active county health departments, and we have over 100 students studying public health in the area. We have a wealth of public health talent in this area. If we can all work together, we could address successfully some of these significant public health problems that involve our community. Furthermore, since our last meeting, the college has made a significant commitment to public health. And that commitment is that they have hired Renee Nahara, I can't pronounce it, who is an epidemiologist with a doctorate in public health from Johns Hopkins Bloomberg School of Public Health. And he is the current chair or director of public health for the college. Renee is also the Susan and Stanley Plotkin Chair for Public Health for the college. So this is a major advance for the college and a real commitment to the area of public health. Renee has a faculty appointment at both Johns Hopkins University and George Mason University. And he has had experience working in public health with the Maryland State Department of Health and with the Anne Arundel County Health Department. I'm going to ask Renee to introduce a new administrative assistant for the section. Renee?
Thank you, Dr. Shar. Yeah, we, at the college, we're building this new nascent Center for Public Health. It's me at the time and our new assistant, Melanie Camoesa. Melanie in the back. She's waving. So Melanie just joined us, and we're starting from scratch at least for the public section at the college since October. But we're collaborating with the section on public health. We have a lot of ideas. We have a lot of energy, even though the wind and cold took it out of me today. But we look forward to not only this event, but events in the future here at the college and around Philadelphia, and collaborating in any way that we can. All that institutional academic knowledge that is being put out by all these schools of public health, all these students, all the dissertations, all the projects, all the posters, we need to put them to work. And so that's one of our main missions here at the college, is to be the host and the organization that uplifts and promotes all of these works that are being done in public health. And tonight's presentation is one of them. So thank you for being here tonight. Thank you, Dr. Shar, for your introduction. And be back.
Thank you. For those of you who are not members of the section, I would urge that you join. For those of you who are members of the section, I would hope that you pay up your annual dues for it. Now I'd like to turn it over to the moderator for this evening, our clerk of the section of public health, Sue Sullivan.
It is so nice to see people in person and not on a small screen. We have a really interesting topic this afternoon or evening. I've had so many things today. Anyway, a great deal of the issues that were really laid bare by the pandemic was the vast inequities of care and of access and of health. And one of the major contributors to that is what is now known as the social determinants of health, which have to do with the environment, housing, with money, with access, and those kinds of things that are not necessarily addressed by healthcare or adequately included with healthcare. So tonight we have a really good presentation showing a project that is attempting to deal with the equity issue and addressing economic determinants of health. And I think that you will find this very interesting and timely. And also, this is an active project that is going on right here in Philadelphia, so we can be very proud of that. We have three wonderful speakers whose biographies were in your announcement, so I'm not going to take the time to read them here, except to say that the first speaker is Dr. George Dellenberg from Children's Hospital of Philadelphia. And you may have also seen an article in the Inquirer in the last 2 weeks about the program that he is going to present. The other two presenters, Dr. Stacey Kallem and Lydia Seymour, are with the Philadelphia Department of Public Health, and they are in charge of the program that is administering this set of things that you're going to hear. So without further ado, I'm going to invite Dr. Dellenberg to begin the presentation, and following him, the two people from the health department, Dr. Perelman and Ms. Seymour, will present, and then we will have time for audience questions, which I will moderate.
Good evening, everybody. It is an honor to be with you. Thank you for joining us in what I hope is really going to be a discussion around some of the ways that we can think differently about our role and responsibility in addressing economic determinants of health. So, by way of setting tonight's agenda, we're going to do a few things. We'll start with some level setting about the effects of poverty, and then define a few examples of cash assistance as a means of addressing poverty, and then move on to exemplifying in a concrete way the potential of cash assistance by talking about some particular methods to address parental and child health. So it's probably useful to ground our discussion in some shared definitions, just to inform how cash assistance programs are set up in the United States. The Federal Poverty Line, or FPL, is an acronym that you may have heard of. It is a measure of income, and we're kind of like in tax season right now. Y'all probably, hopefully, got any W-2s a couple months ago, or Social Security, like retirement. Like everybody sent you all this paperwork, or Lord forbid, emailed it to you in some portal that you have to log into. And so this is all of the income that is taken into consideration for the federal poverty line. The FPL is calculated in a really rigorous way. It is based off of 3 times the cost of the minimum food diet in 1963, adjusted for today's costs. So that is the grounding for so much of the economic policy that we have in place, just to show us what we're really using to kind of like have our discussions. A lot of time we'll talk about low income, and so that's often defined as an individual whose family income is at or below 150% of that poverty line. On the left of the slide there, you'll see for 2 adults and 2 children, that FPL was about $27,500. And so that is probably less than the price of a car if we just went out onto kind of like 19th Street here. And that is what some families are making do with for their entire year. So let's define the problem. Problem is Philly's number 1. And before I get rushed at the stage, I've been in Philadelphia long enough to realize that you don't trash talk Philly. You don't necessarily want to be number one at everything. So Philly is number one when it comes to poverty amongst the most populous cities in the United States. And so the next closest is Houston, for whatever that's worth. But when we look at data, and this graph is from 2019, but the trends kind of continue, you can see that there's about, it's about a 23% poverty rate. It's dipped to just kind of like under that to about 22% poverty rate for Philadelphia in general. But then if you look at specific groups, that value is not the same, right? So this is Philadelphia in total, but you can see the range amongst different racial and ethnic backgrounds. And so when you look at these differences, you'll notice a couple trends. Like poverty has thankfully been going down over time for many different groups. You can see that some groups are noticing upticks compared to the overall line decreasing. And when you look at these trends and consider them historically, you can see, as this article from the Inquirer highlights for us, that the high poverty rate didn't happen by chance. It is the logical outcome of policies that supercharge urbanization, underfunded the school district, and allows racist directors to go unchecked. For decades, leaving people out of the best paying jobs, routinely denying people loans and home mortgages, and then that gives you your effect for some of the racial disparities that you noted on that last graph in terms of our poverty statistics, where 2/3 of Philadelphia's poor are either Black or Latino. And so, what of poverty's effects, right? We're in the College of Physicians, and so this isn't the School of Economics. It's all related. And so, residents of impoverished communities are at increased risk for many different things. You can think about it from a mental health perspective, from a physical health in terms of chronic disease. There's been studies that show that there's higher mortality for those who have lower income or lower wealth overall, as well as lower life expectancy. As you might imagine, there's interplay between and among a lot of these factors, right? So if you have a chronic disease, you might also have a comorbid mental illness. Those both might help to lower your life expectancy and have associated increased morbidity as well as mortality. So it's all connected. It's not, unfortunately, just the adults who are affected. So that previous graph was looking at adults in Philadelphia. This takes a look at our child poverty statistics. So children in the United States are at 16% in terms of the percentage of children living in poverty. For context, this is the largest group out of all of the demographics by age. Is children who live in poverty. And then according to kind of more local data, about 32%, and more recent estimates have it actually increasing, unfortunately, up to about 34% of the children in Philadelphia are living in poverty. Again, if you go ahead and stratify this or break it out by race and ethnicity, you can see that not all children are affected by poverty in the same way. And so once again, this orange line here gives you the rate for all children, and then you can see the breakdown by race and ethnicity there, with Black children at the top at 29.2% compared to a rate of 17.5% for all children in the United States. And just to call it out explicitly, all children are not affected by poverty equally, and it is the racism, not the race. So I don't have a way to stratify by racism on this graph. If I did, I would use that instead. But race is just a proxy for the effects of racism. And whether you conceptualize that as racism being what led to the social construct of race, or the social construct of race leading to the racism that we see in our day-to-day, kind of like systems and interactions, just remember that there's no biologic determinant here that is making people more or less likely to be poor. As we're talking about constructs, I'll introduce a different one just to think about like how does it actually tie together between poverty and outcomes. And so this is from the National Academy of Science, Engineering, and Medicine. And it really has two mechanisms that have been theorized to describe how child poverty leads to child health outcomes. One is an investment pathway, and so that's one in which poverty really undermines the ability of parents to buy what their kids need to thrive. So it means that you can't put food on the table. You can't necessarily afford to have safe and healthy housing. You can't afford medical care. And so all of those have costs associated with them, not just economic costs, but health costs associated with them. And that undermining leads to worse child outcomes. Alternatively, there is a stress pathway. And so that just speaks to the effects of poverty on the milieu in which children grow up. And so the strain on relationships, the strain on the household, how that can affect parenting, how that can affect attachment, all of that will also affect the child's outcomes. And when we look at the data around poverty's impact on kids, we can see a myriad effects. And so children face increased risk of delayed development, of poor educational outcomes, loss of future economic productivity, and then preventable morbidity and mortality. And so when you really take all of this together, both for adults as well as children, addressing poverty is a social ill that is crucial to a healthy America. So that might have seemed like a lot of gloom and doom. We are not without tools to be able to move the needle on this. And so if I were to ask in this room, if you had a fungal infection, what type of medicine would you want for that fungal infection? An anti-fungal, fantastic, right? So if you had a bacterial infection, the problem is bacteria, so I want an antibiotic. If the problem is not having enough money, what is the solution? Money. That is a fantastic thought. And so cash assistance can help with this. And so we're going to talk about cash assistance in a couple different ways. Cash assistance can be direct, so that's literal dollars to spend, or it can be indirect, and so that's kind of in the form of like near cash, it can be called, or vouchers. So just kind of like different ways of giving people more spending power. It can also be thought of as conditional or unconditional. And so the latter means no strings attached. You have the money to spend on the things that you feel you need to spend it on. As a couple examples of these two categories, so for conditional, we have a lot of our public assistance programs. So I've noted a couple here. So WIC, which people think of like the Women, Infant, and Children's program. So that's for families with young kids to be able to address some of their food needs. You have SNAP, which is what was formerly food stamps. You have things like TANF, which is commonly called welfare. So all of these programs are often means tested, so they have some type of eligibility requirement that you have to meet in order to qualify. They often test you on that repeatedly to make sure that you're just jumping through all the right hoops to be able to qualify and get that money. Right? You also have things like tax credits, which are another thing that can be conditional, for example, like on working. So like if you work and if you work a certain amount, then you get additional deductions up until a certain point on your tax credits. We'll talk about that in a little bit. But that's not the only way to do things, and like there are some reasons why those systems exist. But you can also do unconditional cash transfer. And like this idea might have seemed really crazy if it were not for a little virus that caused a whole lot of havoc and resulted in the United States, in the setting of the pandemic, just sending money to like everybody. And that really was a great demonstration of the fact that it's a matter of will, right? Like the United States did not implode when that happened. You could have argued that like it imploded before that happened. But like it was just about like making that decision that like we were going to do these economic impact payments and support people in this time when they needed it with this direct kind of like unconditional, you can do whatever you wanted with that money, right? And so like President Trump's name was on that check, you got that check, you did whatever you wanted with it. And so like that idea of just giving people money to spend on what they need is another way of addressing poverty. So just to highlight the impact of cash assistance, we have on the left here just some stats about how many people receive services specifically for WIC, about 4.7 million Americans, SNAP, 42 million Americans, and then TANF, again, that welfare, 1.8 million Americans. And then in terms of what it helps with, you'll notice that folks who are receiving these benefits will be able to increase their spending on food and different goods, improve educational outcomes, health outcomes. If you look at their income overall, you'll find stabilization rather than some of the big surges and gaps that can lead to kind of like predatory lending and other unsafe and kind of overall risky financial engagements. You'll see increases in full-time employment, actually, and then reduces depression and anxiety. And I think it's important just to highlight in a lot of these that when you think about cash assistance, a lot of the time the narrative is like, if you give people money, you can't really trust them. What if they use it for booze? What if they use it for alcohol? They're going to use it for all of these negative things. And the fact of the matter is, people use it for their needs. And that's not just kind of like an aspiration of a statement. Like that's actually been researched because it was a fair question. Like what do people actually use their money for, right? And it does show that people actually do spend it on the things that they need for them, and especially for their children. We'll talk about that a little bit more. So just looking specifically at, we talked about some of the tax credits, and I'm going to call them out because they are some of the best documented alleviators of poverty that we have, and they are great examples of actually transferring potentially large amounts of cash to families. And we do it every year, like right around this time of year. And so the earned income tax credit is a refundable tax credit. So that means that compared to other tax credits where if the math doesn't work out, you actually don't get any money back. With this, you can actually end up getting up to $6,000 back, which can be a huge amount of money. And on average, about $2,000 back for families. And it's been associated with a lot of different kind of health-related outcomes. So increased food security, increased infant birth rate, increased employment rates of single mothers, child educational achievement, and long-term earnings improvements, increased mental health, decreases in maternal smoking, and decreases in infant mortality, just to name a few. And just to call out again, in terms of just some of the narratives that we hear compared to the data that we see, a lot of times the narrative is like, if people get money, they're not gonna work. Like, why would they bother? But like on the last two slides now, we've seen that there's actually an increase in employment. We've seen the increases in economic productivity. If you think long-term, there's increases in long-term economic productivity for kids, just to call out the facts versus the narratives. And then calling out the expanded child tax credit. So this was another kind of like recent, or more recent iteration of changes in the setting of the COVID pandemic. And so they took the child tax credit, which is a credit available to those with children, as it is so wisely named, and it actually expanded it to decrease some of the hoops that you had to jump through to be able to be eligible for it. And it also changed it so that you could get half of it up front, kind of like as a monthly payment, and then the rest of it would come when you filed your taxes. And in making those two adjustments, kind of making it like fully refundable, rolling it out kind kind of like broadly in that way, they were able to keep millions of children out of poverty. The estimate is that they cut the child poverty rate for the United States in half with this intervention. They were able to show in follow-up tests that when the expanded child tax credit went away, all of that was undone. And so we are back in a position now that we have actually shown that we can avert in a really unfortunate kind of like scientific experiment that we didn't need to do on America's children. So the good news is these aren't just kind of like federal policies that everybody's going to go out here and like write to their legislators. There's things that we can actually do perhaps in our own practice to impact things, or in our own public health practice, physician practice, whatever that might be. So recently I and some colleagues published this piece about the role of health systems in closing the gap. And we use what's called an anti-poverty medicine model. And for us specifically at CHOP, our approach has 4 different pieces for our medical financial partnership. And so the idea of a medical financial partnership is really a cross-sector collaboration where it's the health system working with those in the economic or financial systems to really serve what for them are financial clients, what for us are patients or patients' families, to achieve a shared end, right? Because it's a recognition that financial wellness is intricately, intimately, and kind of uniquely tied to physical, mental, emotional wellness, right? Those two are inextricable. And so all of this, I have to acknowledge for our model here, there's different models kind of around the US, is done in partnership. And that is really taking a strength or assets-based approach to doing this work where we recognize the strength of the community and we lean into that strength of that community. And like, yes, CHOP is fantastic at a lot of things, and could we build this up from scratch? Probably, but we don't need to. We can allocate our resources more effectively by investing in community partnerships to do this work. And so I want to call out our partners here. Campaign for Working Families as our tax prep partner, Benefits Data Trust to do some benefits connection work, Clarify for financial counseling, and the PA Treasury Department actually for the work on child savings accounts. Just to give a sense of some of the impact that we've seen here, with our tax preparation services, where we do free tax preparation for families that is literally happening right now, 30 blocks away. My team is working on that while I'm here. We have been able to get people about over $2,000 on average in terms of the returns. We've been able to return over $700,000 to our West Philadelphia community. For benefits connection, so this is the thought that if I can't actually get you dollars in your pocket, right? Like if I can't get you $2,000 to say, here, go address whatever you need to go address, then I can at least try to save you from spending the money that you're spending on other things, where there might be programs around to help you. So for example, formula. I don't know if you've ever bought formula for yourself or somebody else. It is really expensive. But there's a program that will help you to address it, right? So like WIC will help to pay for formula. But work that's been done by some of my colleagues shows that about 50% of the people who are eligible for WIC are not actually on WIC. And so they are spending a lot of money that they don't have to. That could be money in their pocket, money that they're spending on other costs. And so we work with Benefits Data Trust to identify up to 29 different benefits that families might be eligible for and help to connect them to those benefits so that they can then take those saved dollars and reallocate them to their other life needs. Moving kind of like up the financial wellness ladder, we then think about like for the dollars that you have, what are your long-term financial goals? What are you working on? And so I was so excited to find a financial counseling partner that really did this not in a really didactic, kind of like pedantic way of like the professor wagging their thumb. It was really about what's your goal, what's your dream for your family, and how can we help you to achieve that? And so we've seen average credit score increases of about 52 points, savings built over $2,000. And for some families, this is their means, and we have multiple families be able to get their first homes from working through our program. And then we think long term, in addition to things like getting your first home and trying to think about building intergenerational kind of ability to transfer that home to your kids and kind of change the story and the narrative for your family. The other mechanism that we know for the United States is that education has been a great tool for this. And so we partner with the Treasury Department. They have a program called Keystone Scholars. We're starting for any child born to a Pennsylvania resident. As of 2019, $100 is set aside for them. And so if you have any kids, you have any grandkids born 2019 or later, please go claim your money. So a lot of people aren't aware of this because it reads like a classic scam thing. You get a letter in the mail that says, hey, did you know that for your kid who was born, who you never told me about, I have $100 for you. All you have to do is go to this website and put in some information. And I would tell anybody who gave me that background, like, don't go to that website. That sounds like a scam. And so we're trying to spread the word. We're trying to let people know that this is real. There is this money actually waiting for you. It's going to gain interest for you over time, and you have the opportunity to put in more money. And that money grows. It uses the magic of compound math, where that interest, rather than being something that I'm constantly trying to avoid interest in my life, this is one of the places where you want it to build, right? And so if you put aside $25 a month for a kid starting when they're born, over 18 years, you'll save about $5,000 if you do that math. But with a 6% rate of return, which is just kind of like a basic market rate of return, that'll be about $10,000 that you will have available. And you can use that for four-year college, but maybe not everybody's going to four-year college, two-year college, vocational school, technical school. That money is there for your child, and it's associated with 3 times higher likelihood of applying to college, 4 times higher likelihood of finishing. And so we take these evidence-based interventions and we are putting them into effect right now. But I'm really excited to also have my colleagues share a little bit about what we're thinking about for the future. And so with that, I'm going to turn it over to our other speakers.
We're a little bit shorter than Dr. Dellenberg. But thank you so much for having us, Dr. Dellenberg. That was amazing. And just a fun fact, he and I did residency together, so it is such a treat to be up here now doing grand rounds together. Come in a little closer, Lydia. So I'm Stacey Kallem. I am the Division Director of Maternal Child Family Health at the Philly Health Department. I'm here with my close colleague, Lydia Seymour, who is our CAN coordinator. And we are so excited to talk to you all today about a new program that's going to be happening here in Philly called the Philly Joy Bank, which is a guaranteed income project for pregnant Philadelphians. So before we get into it, we'd be remiss if we didn't thank our funders for this amazing work. So just a shout out to William Penn Foundation, Spring Point Partners, and the City of Philadelphia, without whom everything we're going to talk about wouldn't be possible. So what we're going to do in our time is first talk about some of the racial disparities in birth outcomes in Philadelphia. Then we're going to talk about our group called the Community Action Network, who is behind the Philly Joy Bank, and the strategic planning process we all did to come to this project. And then we're going to spend most of our time really getting into the nitty-gritty of what is the Philly Joy Bank. So first, Dr. Dellenberg set this up perfectly by saying Philly is number 1. So this is another negative Philly is number 1 situation. So this is a chart looking at infant mortality in the US. Infant mortality is defined as the death of an infant in the first year of life. This is showing infant mortality rate, which is the number of deaths per 1,000 live births. And it's, not surprisingly, it's actually the same story as poverty, where of the top 10 most populous US cities, Philadelphia has the highest infant mortality rate. So far higher than places like Chicago, Houston, LA, New York City. We are number 1. And what's really driving that, the major cause of infant mortality, both here in Philly and nationally, is prematurity. So a birth before 37 weeks of life. So diving into the data a little bit deeper, this is similar to some of the trends that Dr. Dallenberg was showing about poverty, but this is looking at infant mortality over time, disaggregated by race and ethnicity. So first, I want to draw your attention to that gray line in the middle. So that's the citywide average. If you were to just look at that line, it's actually like a decent story, right? Like since 2012 to the present, infant mortality has declined in Philadelphia. So that is an amazing thing. However, when we disaggregate by race and ethnicity, you'll see a different story. And I'm just going to say it in plain English because I think sometimes when you look at the graphs, you actually lose the emotional impact. So in Philadelphia, right now, the infant mortality rate for a Black infant is 4 times higher than that of a white infant. Just gonna let that sink in for a moment. And not only that, in the past year, that disparity has actually worsened. When I gave this presentation a year ago or 2 years ago, I was presenting the same data, I was saying 2 times higher, 2.5 times higher, 3 times higher. So in the past year, the Black infant mortality rate went up in Philly, while the white infant mortality rate went down. And that is why we're here today to talk about the Philly Joy Bank, because it is one of our proposed solutions to working on that health disparity. And I'm going to pass it over to Lydia.
Hi everyone, I'm Lydia Seymour. I'm so glad to be here. And I just want to slow things down just a little bit because we have taken in a lot of information and a lot of data. And with that information, I want you guys to realize that there are people and families and babies connected to this information. And so that's why I'm going to slow it down. And I have a quote that I'm going to read, and it's just going to lay the foundation of where we're going. So this quote is by Dr. Monica McLemore. She's an awesome thought leader. She has been doing a lot of research around reproductive justice. And the quote says this: "There is nothing inherent about Black skin that increases risk during pregnancy, except perhaps the overexposure to the real culprit, racism, which can harm a mother's body in real, measurable ways." So I just want you to know, even George made mention of this, that the culprit is not race, it's racism. So what are we going to do about that? So infant mortality in Philadelphia is high. We're at a #1 place. We, the CAN, I'm the CAN coordinator. This is what our approach to addressing that here in Philadelphia. So the CAN is a wonderful coalition of multi-sectors. So we have healthcare, we have health insurance, we have community-based organizations, and most importantly, we have our community lived experience experts. And so we were founded in 2015. We have 3 different grantees, Philadelphia grantees, Healthy Start grantees, Einstein, Maternity Care Coalition, and also Maternity, Child, and Family Health, which, there we go, Stacey and I are a part of, yes, and we're the backbone for this organization. And so what are we doing as the CAN to address that issue in Philadelphia? And so as the CAN, the most powerful part about the CAN is that we have the community at the table. So our community lived experience experts are our voice to the community. So we're not talking about the community and how we can address infant mortality without the community at the table. And so that's so important. So even a little insight into that, I come first as a community lived experience expert, and then I'm here as the CAN coordinator. And so with that, we value our community lived experience experts. So we pay them, and we actually elevate their voice when we're doing initiatives and when we're doing any type of work around infant mortality here. And so we started in 2015, and then we did the strategic planning process about 3 years ago. And the strategic planning process was around infant mortality and prematurity in Philadelphia and the racial disparities around that. And we focused on 3 different areas: chronic health conditions, racism in healthcare, and also holistic mental health. And tonight, I'm going to draw your attention to holistic mental health. So from this work group, we were able to look at more data during this strategic planning process. And the data, you can see, pointed out 4 areas of focus: traumatic, relationship, financial, and also emotional, which are the top stressors for pregnant people from 2018 to 2020. And so I'm going to just focus your attention into the 3rd one, which is financial. And as you can see, over all the groups, financial was huge. It was the top. And so us as a coalition, because we're called the Community Action Network, we took action, and this is the area where we decided to focus. So from that planning process, we saw financial stress as being an area that we wanted to focus on, and that led to a literature review. That literature review led us into the conversation about guaranteed income and pregnancy.
So perfect, we decided to do a project on guaranteed income, but what is guaranteed income? So I just want to level set a little bit. So guaranteed income is the idea of giving money to people, no strings attached, on a regular basis. So Dr. Dallenberg was talking about conditional versus unconditional. Guaranteed income is no strings attached, completely unconditional. So it's really a big departure from traditional benefits programs. And then thank you to Andrew Yang for running for president. One of the things he did was really popularize the idea of universal basic income, but there's an important distinction between the two that I just want to point out. So universal basic income is the idea that like everyone, so literally everyone in the room, everyone in the country would get income back from the country on a regular basis. And then at tax season, it would sort of even out, where people who made more money would give money in, people who made less money would get to keep the universal basic income. Guaranteed income is a related concept, but it's specifically the idea of giving cash to a specific target population of people who you think for some reason particularly deserve or need that income or would benefit from it. So our proposed pilot is a guaranteed income project. And when we were thinking of this, we, as Lydia said, did a really thorough literature review of, well, what can we know about guaranteed income? Do we think this is going to work during pregnancy? Will it have the impact we hope? So I want to give a brief run through of some of the literature that we looked at. So first, what we know about guaranteed income just broadly in the US, and not specific to pregnancy, most of that comes out of Stockton, California from a trial called the SEED trial, where they picked 125 random residents in Stockton, California, who got $500 of cash a month for 2 years, and then it was really well studied, and they saw what happened. And actually, the researchers are in our own backyard. They were from Penn, from the Center of Guaranteed Income Research, who did this study. And what they found really echoes a lot of the research that Dr. Dallenberg shared about other types of cash assistance. That having the guaranteed income, you were more likely to go to full-time employment, your mental health was improved, you had more financial stability. But what I really want to focus on is this infographic, because just like Dr. Dallenberg was talking about with public benefits, in guaranteed income, the detractors will say, well, how are you going to give people just money? Like, what are they going to do with it? I mean, I think, first of all, I think that's sort of a paternalistic approach and isn't respectful of like the dignity and autonomy and intelligence of people to decide how to address their needs. But then we also have data. And this is data about those in the Stockton Seed trial that found that overwhelmingly the money was used for basic needs. So we talk about social determinants of health. That's what this money was used for. It was used for food, it was used for clothing, transportation, utilities. But then unlike the traditional benefits program where you have to go to the WIC office here, or apply for SNAP here, or apply for LIHEAP, the heating program, whatever it is, it was just cash that you could use as you see fit without all those bureaucratic hurdles to address your needs. So that's the SEED trial, just thinking broadly about guaranteed income. But what about the population we care about as maternal, child, and family health, which is pregnant people? So what we know mostly comes from our neighbors from the north, specifically from a group in Manitoba, Canada, where, believe it or not, for the past 20 years, they're actually doing this at scale already, and it's a government policy. It's something called the Healthy Baby Prenatal Benefit. So if you are a low-income pregnant person in Manitoba, Canada, you will get a no-strings-attached guaranteed income during your pregnancy, which is, like, it just boggles the mind that that exists in this country, or not in our country. That's the key point, in Canada. And this has been really well studied because it's been around for 20 years. And what they found is that this modest 10% increase in income had astronomical health impacts. So specifically, it reduced the risk of preterm birth by 17.5%. Like, I'm just gonna emphasize that. I'm a pediatrician. I don't know of any intervention that can impact prematurity and reduce your risk of prematurity at that rate. Like, that is, it's mind-boggling. Similarly, it reduced the risk of low birth weight by 21%. More modestly, but still important, it increased the breastfeeding rate by 4%. And it also reduced population inequities in birth outcomes. So, amazing. They also did a lot of qualitative research to try to understand, well, what's like the mechanism behind these health impacts? And what they found in interviewing participants is that having this extra cash on hand during the critical time of pregnancy, it allowed them to improve nutrition, which we know helps have a healthy pregnancy. It helped them buy things they needed for the baby, so probably reducing stress, having the time and bandwidth to engage in self-care, and then just be ready. They had extra cash on hand, so if there was a financial stressor, they were able to mitigate that in a better way. That's Canada. Canada is obviously not the US. They have a very different healthcare system, a very different social service system. So what do we know about how guaranteed income might help pregnant and parenting folks here in the US? So some of what we know comes from the Mother's Magnolia Trust. They are actually one of sort of the founders of the guaranteed income movement, so I really want to just sort of lift them up. And they've been doing for quite some time a guaranteed, several rounds of pilots in Jackson, Mississippi, where they've been giving $1,000 a month for a year to Black mothers specifically who are living in affordable housing. And I want to encourage you all, if you have some time or feel interested, to take a look at Ms. Magazine. They did this phenomenal view of the Mother's Magnolia Trust, where they had all these different articles highlighting different participants, really speaking in their own voice about how this impacted them. I'm just going to share with you one quote that's, I think, a really good example of how this program impacted lives. And it comes from Erica. And she says, "I used to have to work 4 or 5 jobs to make ends meet. Having guaranteed income gave me more time to spend with my kids. It helped me build myself up, financially, mentally, and emotionally." And what Erica said was really echoed by all of the participants. So in the research they did, they found that their participants were more hopeful about the future, they could fulfill their basic needs, they had more time to spend with their kids, and were able to use the money to support their child's education. And then last, I'm going to talk about, or second to last, one other guaranteed income trial in the US that's actually received a lot of press lately, like New York Times articles, so you may have seen this one. It's called Baby's First Years. And this is a more traditional randomized controlled trial where they're giving $1,000 a month it's 1,000 low-income mother-infant dyads who are randomized either to receive the high cash group of $333 a month, no strings attached, or the low cash group, so the control group, where they got $20 a month for the first 52 months of their child's life. And they're from a bunch of different cities in the US. And this research is still very much ongoing, but what they found so far is that those who got that larger cash payment, that $333 a month, they spent more time in early learning activities and also more money on child-specific goods. And what made the big news splash is that it also showed measurable changes in brain activity when they put the baby into scanners, which is pretty crazy. And this is the last one. Last but not least, the other project that I want to mention that's happening in the US in the guaranteed income space is really the inspiration for the Philly Joy Bank. And it's a group out of San Francisco called the Abundant Birth Project. And similar to us, this project is also born from a collective impact group that is working on infant mortality that is associated with their city health department. And what they're doing is they're giving $1,000 a month specifically to Black and Pacific Islander pregnant people, because in San Francisco, that's who has worse birth outcomes. Their project is ongoing, so they don't have research to report yet, but what they do have to report, we're really excited for them, is they got a major grant from their state and are going to be expanding the Abundant Birth Project to many more cities in California and doing a much larger evaluation, so they will be able to speak about birth outcomes, which is really exciting. So we actually formally consult with them on our project, and they're really the inspiration for the project we're about to present with you. So I just want to connect the dots for everyone of, okay, so we talked about birth outcomes, we talked about guaranteed income, we have this project, like how do we think this is all actually going to work together? So Dr. Dallenberg, if you remember back to his slide, talked about the stress investment pathway that is the link between poverty and poor health outcomes. So our conceptual model for how guaranteed income will work is really the strength-based inverse of that. So how do we think guaranteed income is going to help birth outcomes? So I'm actually just going to briefly walk us through this conceptual model. So we think that having the guaranteed income in pregnancy, first of all, will increase one's feelings of dignity, power, and autonomy. You have this extra cash, you can use it as you see fit. Really tangibly, it's going to improve financial stability. And then we think that'll really impact a lot of these short-term outcomes. So first of all, we think that having extra cash during pregnancy will improve access to healthcare. It'll importantly improve your ability to address basic needs. So things like the social determinants of health. So instead of having the housing program, the food program, the transportation program, if we just give people money, they can address all of those social determinants as they need to. We also think really importantly that having extra cash during what is, for many people, a stressful time, pregnancy and a new baby, having extra cash will decrease stress. There's actually a strong linkage between stress and prematurity, so we think that'll be an effect. And then lastly, once the baby's born, having extra cash on hand will allow parents to spend money to buy things or like invest in high quality childcare, improve parent-child engagement. All of those things in totality will improve parental health and well-being, improve infant health and well-being, and ultimately achieve our guiding light of reducing disparities in birth outcomes.
All right. And so with all of that, the CAN decided to create what is called the Philly Joy Bank. And so we had all this insight into the benefits of guaranteed income. And the Philly Joy Bank was designed by us, the coalition with all the multi-sectors. And we really wanted it to aim at infant mortality and also the racial disparities around it. And so the Philly Joy Bank is we're going to give out 200 to 250 Philadelphians $1,000 a month over the course of 18 months. So that's within pregnancy and then up to 12 months after. This is huge. And so in addition to that cash supplement during pregnancy and after postpartum, we are also offering voluntary offerings. So we'll offer financial coaching, benefits counseling, doula support, breastfeeding support. All of those things are so necessary in pregnancy. So we're going to offer these things as well for the Philly Joy Bank. And from here, I just want to pause to shout out our team. I realized that we wouldn't be here without all of these wonderful people that play a huge part in the coalition. So we have our community lived experience expert. We have over 15 community lived experience experts. But as you can see on the screen, the Department of Health, we have CHOP, we have so many people, Drexel, Maternity Care Coalition, and we're backed. Our fiscal sponsor is the Mayor's Fund Office, and so we're just grateful. Also Strategy Arts, I could keep naming, I don't want to forget anybody, but we have so many people that come to the table, and this is why we're here. So I wanted to shout them out. And so with the strategic planning process, we had to narrow in on who we wanted to focus on. And so we looked at specific neighborhoods that had very low birth weights. And we wanted to go to those areas first because that's what we want to address first. And so we looked at Cobbs Creek, Strawberry Mansion, and Nicetown, Tioga. And those were the highest and lowest birth weights. And as you can see in the third column, a lot of those babies are Black infants. So from there, we had to make the decision what was a meaningful amount that we could give out? And also, what was the income limit that we were going to set as a standard? And so we looked at $1,000 a month. As Stacey mentioned, we got mentored by Abundant Birth, the project, and they were wonderful in letting us giving us insight into what was the needs of their community. And so we were able to actually look at our community and see what would be meaningful, what would be something that they could use that could help them out of poverty. And so we decided on $1,000 a month. And then the income limit. We looked at families that fall into that gap where they don't necessarily make the gap for public assistance, but they don't have a living wage. And so we wanted to cover that area. And so we decided to include families that made $100,000 a year or less. So from here, I'm going to give it to Stacey.
Thanks, Lydia. And I'm just going to end by talking about a few other key aspects of our program. So one that's really important is we want to make sure that participants in the Philly Joy Bank avoid something called the benefits cliff. And what that is if you're on public benefits and all of a sudden get a relatively even small increase in your income, all of a sudden you might no longer qualify for all those benefits programs and ultimately actually be worse off than you were if you hadn't gotten that extra bit of income. So that is obviously something we want to avoid for Philly Joy Bank participants. And we're going to be mitigating that through two different strategies. So one, we have our applications into the state, and we're pretty sure they're going to be accepted because they've approved it for other similar pilots, but to get state waivers for some specific public benefits, which I listed here. And what that means is, let's say that you currently qualify for SNAP. When SNAP is determining your income, if you're in the Philly Joy Bank, they're going to ignore the Philly Joy Bank. They're not going to count that as income. So you will remain eligible for those benefits just as you would if you didn't have this additional income. Second, we're going to be offering voluntary benefits counseling for all program participants, so that if they have specific questions on how this will impact them personally, they can sit with a qualified professional and get a really detailed insight onto what may or may not happen. So now I'm going to shift gears slightly and talk about what we hope to learn from the Philly Joy Bank and sort of our evaluation principles. And I will confess, we have still not finalized our evaluation partner, so it's a work in progress, but we have done a lot of the formative work of deciding what matters to us in our group when we're doing research. So I'm going to walk you through what matters to our CAN coalition. So the first thing that was really important to our group is that the Philly Joy Bank is not a research study. It is an implementation pilot that we are going to evaluate. And that's an important nuance to us because the research portion of the Philly Joy Bank will actually be voluntary to program participants. And that's because this would be a whole talk in and of itself, but there's a long history of academics and researchers coming into communities of color, doing research and causing harm. So our goal for the project is to really build up trust between community and researchers, and we thought that key to doing that is to make the research voluntary. Along similar lines, in the Philly Joy Bank, we will be hiring community research partners because community researchers because representation matters. So when we are doing interviews or administering surveys, that will be done by members of the community. We're also planning a mixed methods evaluation, meaning we'll be collecting both quantitative but also qualitative data. Because we think for a project like this, that qualitative rich narrative data might actually be more effective for advocacy, ultimately, than the quantitative. Another thing that's really important to us is we are so aware that the people in our program will be pregnant or have a new baby, and they are busy. So we want to make sure that our research is not just this other stress or thing where they have to fill out these long surveys every week or every month. So one of our goals is to really minimize the research burden. And then last, we want to make sure that the research we're doing and the questions we are answering are important with policymakers. To that end, we are actually meeting with policymakers to ask them that question. If I wanted to pitch a guaranteed income project to you, what would you want to know about it? And we'll be using that to really inform our evaluation. And then this is a slide I showed earlier of looking at our conceptual model. I'm not going to read through it again, but just want to highlight that for the pilot, which is only 250 people, what we're focusing on is really learning about feasibility and acceptability. So can we do the program and do people like it? And then also looking at short-term outcomes. So everything in that sort of red box. We hope that over time we will have enough cohorts in the Philly Joy Bank where we'll have enough statistical power to look at disparities in birth outcomes. But with 250 people, we're really focusing on the more intermediate outcomes. So last, whenever we talk about guaranteed income, basically the first question people ask is like, this all sounds great for a pilot, like for real, like this is gonna happen? So I'm going to preempt any of the questions about pathways, sustainability, and scalability by talking about that right now. I'm happy to talk about it more. I just want to say it at the outset. So we're thinking about the scalability pathway for a program like this in 3 different ways. So the first is, can we take existing cash transfer programs, so actually the ones Dr. Dallenberg talked about in the beginning, and do policy fixes to make them more guaranteed income-like? So for example, the earned income tax credit. There's this huge effort around earned income tax credit modernization, meaning can it be dispersed monthly instead of at the end of the year to make it more guaranteed income-like? Can we increase the amount of funds people get from earned income tax credit? So there's a federal earned income tax credit. Some states actually have their own earned tax credit. Pennsylvania does not. Stick around in April, there's going to be a bill introduced to have an earned income tax credit here in Pennsylvania, so please pay attention to that. Also the child tax credit, which Dr. Dallenberg talked about. It was amazing during COVID-19. Can something like that come back? And last, TANF, which is sort of the traditional program, welfare program or giving cash to people, has a whole host of requirements, work requirements, only a number of certain years of benefits, so can that be reformed? So that's sort of bucket number 1 we're thinking through. Bucket number 2 is there's specific federal funding for maternal and child health. It's earmarked to use to reduce disparities in birth outcomes. It actually funds most of the work of my division comes from these federal funds. And so like it's Title V, Healthy Start, I'll throw Medicaid in that. But specifically for Title V and Healthy Start, there's a prohibition against using those funds to give cash to people. As a side note, there was this big infant mortality grant that we were all pumped to apply for, and then on page 43 in the fine print, it said, cannot give cash directly to people. So that's a policy fix and feels actually quite doable. And to that end, we're actually meeting with the head of HRSA to talk about this specific, or the Maternal Child Health Bureau at HRSA to talk about how can we get rid of that prohibition. And then last, Potentially more far-fetched, but maybe not, because a presidential candidate talked about this. But could there be universal basic income in this country? And if there was, it would certainly improve birth outcomes. So with that, we are happy to answer any questions. I do want to mention that all of the beautiful artwork you saw throughout our presentation was done by a local artist, Jazz Malone. And then I will put up all of our contact information. We're happy to chat after, but I think we're going to do a Q&A portion right now. So thank you for your attention.
Okay, well, this was a wonderful start to our grand rounds. A very, very exciting project. So we're going to have time for a few questions for our presenters. So if you raise your hand, I will call on you. Walter.
Well, let me start by saying that this could potentially be the most exciting public health program that I've ever seen in my entire professional career here in Philadelphia. So I just think you guys should be totally commended for being here. Now let me say that I had a long conversation with the district attorney, Larry Prosser, about the fact that gun violence is our biggest public problem right now that we're faced with. And my plea to you is that somehow or another we don't drop this thing after 1 or 2 years. I know you're saying research is not the aim of the whole thing, but somehow or another we have to show that this a sanitary benefit could be, doing something for ACEs, could be doing something for gun violence, and raising children to be much more responsible citizens of this country. So I'd like to see your comments about maybe whether you have that kind of vision also.
So first of all, is this on? Yeah. First of all, thank you. That is remarkable that you said that this is so exciting. And you must know Dr. Ruth Abaya, because her voice was in my head when you were saying that. So if you don't know Dr.
I told Ruth also the same thing.
If you don't know Dr. Ruth Abaya, she
You
is
should know that Walter was a health commissioner at the Philadelphia Department of Health.
well, I take that compliment even more deeply now. So thank you. But yeah, so Dr. Ruth Abaya, she is at the health department and also the manager of the I forget her title, but she works on gun violence on the public health approach. So two things that I've learned from Dr. Abaya. One, she's actually thinking about guaranteed income specifically as a tool to address gun violence. There's actually a few different city pilots around guaranteed income happening right now, and we meet monthly to learn from each other. So Ruth's pilot is to specifically look at those who are victims of gun violence and are in hospital-based violence prevention programs, and to give them guaranteed income in that critical time after an injury to see if it prevents future injury. So that's sort of one thing. The bigger picture, what Dr. Abaya has also pleaded with all of us in those meetings is, when you're doing your projects and you're looking at guaranteed income for your outcome, could you also please look at it for gun violence and safety and community violence? Because we think that there will be a really big impact on those outcomes as well.
Any other questions or comments?
What percentage of the participants in your study are participating also in letting their data be collected?
So we probably should have made this clear, we have not launched yet. So we are still in the fundraising phase. We have a big press announcement on Monday, and it'll probably go up the news, so stay tuned. But we have received 2 large contributions. We are over halfway to our fundraising goal, and we expect to be able to enroll people in the program in early 2024. So I will answer that question for you when you're here.
But just to clarify what I'm hearing, and I don't know if you can say it because you're a government official, but it seems like there's opportunity for additional people to donate.
If you go on the Philadelphia City Fund website, it's actually a button.
I guess I have the microphone now. Could you talk a little bit about how you select who qualifies, who doesn't qualify for your own program, and how do you pick who gets it and who doesn't?
Sorry, I feel bad about the answer. I'm talking the mic a little. So the eligibility requirements for the Philly Joy Bank are 1, you have to be pregnant. 2, you have to live in one of those 3 neighborhoods that Lydia showed. So that's Nice Cayuga, Cobbs Creek, and Strawberry Mansion that all have the highest rates of very low birth weight in Philadelphia. And 3, your household income needs to be less than $100,000 a month. So as far as from like within that pool, how we're gonna pick people, we have a year-long planning process, and that's what we're really gonna be working on as a can, is those nitty-gritty questions of like, what do we do if more than 250 people want to be in the program? So that's a to-be-continued answer.
Stacey, I have a question.
Yes.
What role do the community groups that you're working with have in actual contact or work with the individuals that are chosen? What services do they provide and how do they interact?
Sure. So for our community lived experience experts, as I was stating in our slides, they are so important to this work. And so they play leadership roles, they play co-chairs within the coalition, and so they're part of woven into every part of the selection process.
Are they actually going to interact personally with the individuals that are chosen?
So that is the hope. So one of the things that we're going to do is we're going to hire community lived experience. Yeah, a Philly Joy navigator, but it's a community lived experience expert that will be on the team with the research team to represent the community along with the research team. And so yes, they'll be involved in that process.
Other questions? Wait for the mic.
Don't give me a microphone.
We have to give our new assistant some work to do.
I love it. So listening to the audience, one of the moments I got the biggest reaction was when you explained how the poverty line was calculated. 3 times the cost of the minimum food diet in 1963, adjusted for today. So the assumption being that a house should spend 1/3 of their income on food. How do you think a more sane calculation of that number would influence like the numbers that you work with and that you do? So you understand my question. Go ahead.
So thank you for the question. In 2011, I think it was, there was another measure actually introduced, which is just kind of like mentioned last, which is called the supplemental poverty measure. And so what that does, instead of just looking at income, it actually looks at income, but takes into consideration like what other benefits you're getting, right? Because like that might actually help to defray some of the costs. But it also takes into consideration kind of like what other life expenses you might have. And so it gives you a more holistic sense of a family or an individual's financial status. And then from there, I think we still have to make determinations about just kind of like how little money are we letting people kind of like subsist on. And that you can kind of like empirically look at like how hard is it for people to live on things and kind of like get qualitative information, but that will eventually come down to a bit of like a moral plus kind of policy determination. And there's like different calculators that you can use, which I think is what Stacey's about to talk about.
You can tell we're friends. It's really like passing on nicely. So yeah, for the Philly Joy Bank, we talked about like what should the upper income limit be, and should we use the federal poverty line? And specifically chose not to, as Lydia talked about. And instead, we used a few different living wage calculators. So that's really getting at like, do you make enough of a living wage? So can you thrive as a person, not just sort of scrape by? And that is what led us to the $100,000 a year for a family of 4. And there's a few different living wage calculators, and she's actually in the audience. UNP is one who did all this research. If you're interested, I recommend you chat with her.
We want to have a big hand for our speakers. Thank you very much.